is March 25th, Tuesday, and this is the afternoon meeting of House Healthcare. And today we're sort of being introduced to the topic of private equity in medicine, healthcare. We do have a bill on our wall, H71, which we're not going to do a walkthrough yet, but frankly, it's a topic that we have never covered before in this committee. And I thought we should maybe get a little bit of an education on it. And we have with us Nancy Kane, and she's going to tell us about private equity in medicine. So welcome, Nancy. Thank you for joining us today and being flexible with your schedule. We really appreciate that.
Well, I have more flexibility than you do, but I appreciate sticking with the same time. So I thought I would share with you some slides of a talk I gave to a group of people at Harvard about a month ago who are very interested in private equity in healthcare. But I can go through these pretty quickly. And then also I can talk about my experience monitoring the Steward healthcare system because I was the official monitor of the financial data back in 2013 to 15 for the Attorney General's office. And then in 2023-24, after I started screaming that something terrible was going on, I got invited to consult with the Executive Office for Healthcare, Executive Office of Health and Human Services, as we tried to figure out, just before Steward went bankrupt, for about 6 months, how to address the crisis. Right. So I can talk about that later, but I thought it's always good to have some sense of what private equity is. And I thought might be good to start with that and then come back to my experience if you want to ask about it or not. Let me just start with what is private equity. And the most important thing I think to realize is they have to get their money out. So they put their money into an organization. They usually buy an existing organization. They're not startup funding, but they have to get their money out because of the way they raise their money. It's usually limited partners, usually universities, pensions, foundations, give them the money, looking for a big return. But they want it back within 10 years, and it's often less than that. And so they usually buy existing companies, and they only put about 30% equity in. Most of it is in debt, and that debt lands on the books of the company they acquire, which makes these things if they don't succeed, those companies are very likely to go bankrupt, which is exactly what's been going on lately in healthcare. But so that's just a very different mentality than a venture company or even a publicly held private, for-profit company. They usually are owners of a company that they want to see, succeed and go on in perpetuity. Private equity has to exit. So the number one thing to ask is, how do you plan to exit? Because they have some ugly ways of doing that. So let me go on to the next slide. This is an example of a company I wrote a case about years ago, but they finally went bankrupt. I knew they would eventually have to finally go all the way, but they started off as a privately owned by an individual, privately owned emergency physician staffing company in the 70s in Texas. After about 25 years of existence, they sold to a privately owned bus company called Laidlaw for $336 million. That was in 1997. 7 or 8 years later, they got acquired by a PE firm and taken public. And so a lot of PE firm exit strategies is acquire something and then try to get it public quickly. So they acquire it for $336 million and take it public about a few months later for $820 million. So that's what the private equity companies love to do, is get in there, grab something that's undervalued, do some cost cutting or some restructuring, and then take it public and get out. And they went public for 6 years, and then they went private again with a private equity firm in 2011 for $3 billion. So meanwhile, the people who had this public stock in that made some good money if they held on long enough. Then this PE firm, Clayton, Dubilier Rice, took it public in 2 years for $4 billion valuation. And then they went private again back in 2018 for $10 billion, of which $7 billion was debt. And in 2023, they filed bankruptcy because a lot of this was financed with debt. I might add their strategy and their source of profit was they were the principal architects of surprise billing. And when Congress tried to stop that they kind of gradually got more effective at stopping it, and that pretty much dried up their profits. But you can see this in and out, that no private equity firm wants to hold on for long. They want to either go public, sell it to another private equity firm, shut it down in some way, sell off pieces, whatever they can do to get their money back out. And that's an important thing to just always be concerned about. When the company, if you're ever overseeing a private equity deal, your first question is, what's your exit strategy? And you have to tell us if you're not going to do it that way. And you might not approve the original exit strategy. Okay, next slide. So private equity has grown like gangbusters in the past 20, 30 years. It went up from 4% of all corporate equity in the year 2000 to 20% now. And that's because of cheap debt, because so much of their acquisitions are financed with debt, but also because we had an act in the past in the Depression that said the companies selling anything to the public couldn't have a lot of private investors. They had to be public. They had to disclose everything to the public in a regulatory body like the SEC. But in 1996, for some reason, Congress removed that restraint so that you can have more than 100 private investors and make investments and not have to disclose what you're doing to the public or even fully to your investors. So and with low interest rates, the PE model has just gone gangbusters. Okay, next slide. So this gives you a sense of of how much private equity has grown since 2010, when it was 1.6 trillion. As of 2022, 5.3 trillion, and projected to grow at least to 6.5 trillion by 2028, or depending on how the market goes, up to 10 trillion. So it's a huge chunk of our economy these days. Next slide. And it's also become a huge chunk of equity in healthcare. So this slide gives you some sense of how many deals per year they've gone for in 2000. And this is just from 2010 to 2000, I think 20. Yeah, we started off at about in 2010 with maybe 100, under a couple hundred deals. So now almost 937, I think it is, in 2019, and the valuations are going up. So it's grown dramatically in healthcare, and we can talk a little bit about why that is as we get into some of the more the details by healthcare sector. And the next slide, this is worth spending a minute on. You can see this is a count of buyouts in healthcare by sector. So the blue column, the part that's blue, are outpatient clinics, excuse me, and particularly physician practices. And that is actually something that has gone under the radar in most states because nobody really reviews acquisitions of physician practices. It's not usually a big enough deal for someone to say we have to put DON requirements or any kind of state regulatory oversight over the acquisition of physician practices. So you can see that's a big chunk and probably the largest chunk of deals throughout the period of 2010 to 2020. The orange is elder care, nursing homes and care for the disabled, but mostly elder care, nursing homes in particular. And you can see that they started back in 2010, maybe 20, 25, under 30, and now they're up to growing 30, 40, 50, 60. They're getting more and more into elder care. And that has not had happy outcomes, and I'll talk about why in a minute. The gray looks like a small number of deals, but it's actually a large number of assets, and that's hospitals. And that accelerated after 2014, probably partly because of Steward Healthcare, which expanded dramatically using the private equity model. And when it left Massachusetts and acquired 30 other hospitals or 25 other hospitals in Utah and Texas and Florida and Connecticut, they just exploded. And then the yellow. Yeah.
Can I interrupt you really briefly, Nancy? Do you mind taking questions?
No, I don't mind.
We have two questions. Mari has a question and then Daisy after that.
Mine actually is about the next thing you're going to talk about. I'd be curious about examples of what PE in pharmacy, what specific pharmaceutical entities.
I think it's largely things like new not chemical, but bio drugs that need some small firms might have got the patent, but they don't have the capital to make it go into the market. And so you have a couple of choices if you're a small pharmacy inventor, or even a large company that has a small discovery they want to joint venture to get the capital to take it, disseminate it and get it through clinical trials. So I don't know exactly the names of the companies because I haven't looked at the pharma sector that much. But you have someone coming in from the, I think after me from the private equity stakeholder project, and they could probably tell you the names of the companies. They have a whole website on it.
Great, thank you.
And I think Daisy has a clarifying question.
Yeah, I just wanted to, can you go back up to where you were saying that there was it 2014, there was a influx in the number of hospitals and
Yeah, that are
Yeah.
PE that became owned by PE. Yeah, after 2000, it's this slide. You can see it's the gray.
yeah, and you gave a reason for why that was. Can you repeat that?
Oh, yeah, I think 2015 is when Steward Healthcare went on sold their Massachusetts assets to a REIT and used that cash to go on a buying sprees, and they're owned by Cerberus Private Equity. So those acquisitions, fueled by the sale of Massachusetts hospitals, enabled them to buy about 25, 30 hospitals in 4 or 5 states.
Got it. Thank you.
Okay, so it looks like, not a big number of deals, but very high value deals in the hospital sector. Okay, the next slide. Oh,
one
go
more.
ahead. Was there another question?
One more question Woody has.
So how do these private equity firms, how do they get money out of the hospitals? I mean,
Well,
I guess reducing, I guess, number of workers, maybe changing pension funds or going after those. I hope you'll explain that.
I will get there. There are multiple ways that they get their money out. When Steward was acquired by Cerberus originally, it was the original Catholic chain called Caritas Health System in Massachusetts that served mostly low-income populations. And we were all sitting there going, why is a private equity how are they ever going to see their giant returns acquiring a hospital system that serves a bunch of low-income communities that are predominantly Medicare and Medicaid? And I can tell you a lot about how they did it. And I do have a slide that talks about the different ways they do it, but it's largely selling their real estate to a REIT for the cash and then trying to do a roll-up. And if they're, buying other hospitals and trying to create economies of scale and market share power. And if that doesn't work, trying to get another PE firm to buy them. And if that doesn't work, you implode. And I can talk again. Steward was a particularly pernicious private equity deal, and Cerberus, the private equity company that owned them, bailed out in around 2020. Probably should have closed them then because they were already bankrupt. They were bankrupt earlier, way earlier than they went bankrupt. They were being kept alive by the REIT. So that was particularly, and the REIT was a publicly owned company called Medical Properties Trust that was lying to its investors. And I hope they get sued a lot, but so I will come to that. But the REIT, selling your assets to a REIT and then they paid Cerberus a huge amount of that money just to pay back its investors. But they also cut costs. They also stopped paying their bills. Excuse me. And I'll show you some slides on that in a minute. More generally, not just about Steward. So to get more into the hospitals, sorry, I have some kind of laryngitis going on here. Steward, private equity is mostly in about 15 states. It's sprinkled around other states, but they like states that don't have a strong regulatory infrastructure. So you can see that, New Mexico is almost over a third of their hospitals are private equity owned. Texas is big, Arizona, Oklahoma, places where the state doesn't have a strong regulatory oversight of hospital investors and mergers and acquisitions. So Massachusetts would have been on here, actually it was just 10 hospitals. So it was under 10 by the time they made this slide, but it's highly concentrated in 15 states with over 10% of the hospitals in those states in 10 of those 15 states. So they go for states where there's not a strong regulatory effort, and also the opportunity to make money off commercial payers. If you go to the next slide, it's not just acute hospitals they're after. Only about a third of the hospitals they acquire are community acute, not acute hospitals. They like rehab hospitals. They really like psych hospitals, and they also own long-term care, long-term acute. They're called LTAC hospitals. A quarter of them serve rural populations. And so that's sort of the psych piece in particular is of concern because we have a huge shortage and no one wants to get into the psych business. So private is like an open door for the psych business. There are also these companies that are private equity owned called hospital management companies that don't own the hospital, but they get the contract, the long-term contract to manage them over time. And those can be private equity based management companies, which can do some of the same things, and which I'll show you in a minute that Stuart did. Okay, next slide. Oh, these are some of the big private equity firms. Apollo Global Management is the biggest. Apollo Global Management is the one that owns all the Stewart Hospital real estate now. And when they went bankrupt, Apollo would not give up their claim. They owned the real estate. It was the operating company that went bankrupt. So when the state of Massachusetts tried to say, well, let us keep these 5, well, the operating company said, fine, we're done. We owe more money than we have. But the real estate company that owned the physical assets said, you got to keep paying our leases. So this has been we've had a huge fight over the ownership of the real estate of the hospitals that the operating company sold off to generate the cash to expand and pay dividends and make themselves wealthy. So not all of them are in acute care. Some of them are in rehab, psych, or surgery centers. You can see there's probably 10 or 12 big names that you can look into. If you see that name, you can look them up and get an idea of what their attitude is in healthcare and how they've behaved. This is a summary of all the literature this is from a British Medical Journal sort of meta-analysis of what's private equity's impact on hospital care. Because there's like 25, 30 studies in here summarized. And they looked at 4 different attributes of performance. Sorry. Healthcare outcomes, which is, did they live or die, I guess, or did the patients, be outcomes were they as expected? And you can see that the gray is neutral, the red is negative, and the green is positive. So I would say of the 7 or 8 studies that did health outcome analysis, the evidence was mixed. The next column, which is cost to the patients or the payers, was universally negative, a little bit of neutral and no positive. So in other words, when private equity comes in, the payer or the patients generally saw higher costs. The cost to the operator, in other words, did they make the operator, like the hospital, more efficient? Evidence mixed. Quality, evidence really mixed, neutral to mixed. So the number one thing you come away with is it makes it more expensive for the patient or the payer. Number 2, it doesn't necessarily make them a lot more efficient. Number 3, it may actually hurt patients in terms of outcomes and quality. So you can't say they're running these places better than when they were not private equity owned.
We have another question, Leslie.
Thank you. I was just wondering if these are all US hospitals printed in BMJ, trying to understand that connection.
I think it's mostly US, yes.
So
Although they do own hospitals all over the world, especially Europe.
Thank you.
Yeah, that's a good question, and I don't know, but I think it's probably all over. It's probably mostly US that has the data to do this kind of analysis. Okay, now we'll talk a little bit about physician practices, and again, that's the fastest growing place for private equity to make deals. This is a figure showing from 2010 to 20. Gotta see my printout here. Yeah. Anyway, what the number of deals of physician practices by specialty. And I think it's 10 to 2021. You can see it growing really fast in some of the nice, easy outpatient standalone type of practices like dermatology and ophthalmology. But then there are also primary care. I mean, radiology is standalone often, but they're getting into primary care, cardiology, orthopedics, gastroenterology as well. So that's a number of deals, and you can see it's gone from a minuscule amount in 2012, I get 10, up to over 1,000 by 2020. And that's very worse, and I'll show you why in the next couple slides. If you go to the next slide, what they're trying to do when they acquire physician practices is acquire enough of them within one metropolitan statistical area, MSA, within one market to acquire a dominant market share. And you can see that the number of MSAs where an equity firm has a dominant market share in a specialty has gone way up since 2012. Dermatology, I can't read all those. 2 slides to gastroenterology, OBGYN. So they have a 30% or greater market share in a lot more MSAs. And the next slide talks about why that's important. So column A here says, how much more expensive is the PE practice to a non-PE practice? And here's by specialty. And you can see in gastroenterology that a PE-owned practice is 14% more expensive than a non-PE gastroenterology practice. But if they have a 30% or greater market share in that MSA, it's even more expensive, 18% relative to non-PE. And the expenditures per patient in the 30% market share is higher. It's about the same if it's PE or non-PE for gastroenterology, but it is higher in some of the specialties. So the strategy is basically acquire enough practices within a competitive market that you can negotiate higher rates. Okay, any questions about that?
Yeah, Tucker, you have a question?
So in terms of the results in these particular places that are being bought up, is the quality as good?
Well, in the hospitals, it's clearly not. And there has not been a really robust study of
What
quality.
about these are physician practices?
I don't think they've.
The same thing there too?
Probably similar. I mean, I've heard anecdotally that it's deteriorates, what happens sometimes is the quality stays the same. The doctor's the same doc. We had I heard of one of my physician execs from the program I used to run. We do reunions, and they came last year. One woman was a fertility doc, and when her hospital sold her practice to private equity. And she said, first of all, they've said, you stop seeing Medicaid patients. Secondly, you stop doing procedures that don't make money. Thirdly, they moved her to an office that wasn't anywhere nearly as nice as she had. Fourth, she had to order all her lab tests through a private equity owned lab. I can't imagine that improves quality, but those are the kinds of things they do to make more money.
And my other part of the question is, in Vermont, I don't know whether you know the answer to this or not. Do we have any of these
I don't know the answer.
physician practices being bought up or hospitals being bought?
I don't know. And unless you're asking the providers to tell you, you won't know.
Mari? You have a question?
Can I respond to?
Yes, if you definitively know an answer.
There are at least 2, I think they're FQHCs that are affiliated in some ways with a private equity organization, but it's not that they got bought out. It's like I don't know specifically what the arrangement is. It's like an administrative thing, but it's not a buyout.
It might be a management service organization where they run the management.
No.
They manage the clinics and do the billing and all that, but they don't own the clinics.
There's some sort of an arrangement with the clinic in my town. And there's a big kerfluffle about it.
Yeah.
They probably not interested in the hospitals because all of them are nonprofit, aren't they?
Well, that's what they start off as, and then they acquire them and convert them. Caritas was a nonprofit Catholic chain. But you've got hospitals closing right and left. And some boards say, well, we really we just need another source of capital, and they go to private equity. So, yeah, nonprofit, it doesn't matter what your status is at the moment. It's the status that you might have to switch to if you're going bankrupt and have no other sources of access to capital. That's the thing about Massachusetts. Caritas looked for 4 or 5 years for a nonprofit acquirer, and no one wanted them because of their huge pension obligation that the Roman Catholic Church of Boston had kind of left them with. It was a couple $100 million that no one wanted to take that on. So there might have been other alternatives that they'd been willing to, take Catholic off the name, but for some reason, the Catholic Church preferred Cerberus to Mass General.
I know
Of
you
course-
had mentioned at the very beginning, if you get through your slides, you were going to tell us the Stewart story, and I'm actually really looking forward to
Mhm.
that.
Well,
So
yeah.
let
It's a very long story, but I can tell you parts of it. But we were all scratching our heads when we found the Catholic Church preferred Cerberus, because I don't know if you know what Cerberus means. It's a two-headed dog that guards the gates of hell.
service.
Cerberus, the name. So we are all sort of shocked. But anyway, at the time, Caritas was out of cash, and they didn't have the cash to fund their pension fund, and it was a problem. So nonprofit status doesn't keep you from deciding that you need capital, and you go private equity. So
Thank you.
that's just okay. I'll keep on going, then I'll come back, because if you want me to, I know I'm supposed to stop in 1 minute. So nursing homes are also big popular places for private equity to acquire them. And if we go down to that slide, the next slide, the comparison, the nursing home outcomes have been studied more than most because there's a good database for it. And what you see is between private equity owned and non-private equity owned, the overall 5-star rating, the PE owns are lower or worse. Staff per day, worse. Nursing assistant, which is the person who really helps you, the patient the most, fewer hours. And then look at the cost differences. Management fee, they charge a management fee, they have a rent, they have interest expense way higher than a non-PE owned nursing home. So a reduction, in other words, more people reduce their mobility, slightly higher mortality rate, and a much more bill per patient. And the next slide shows you how why those costs go up so much. The nursing home itself becomes a core of its former self, and it outsources management. It outsources, it sells the property to a REIT. So it pays leases. It outsources physical therapy. It outsources pharmacy. It outsources consulting, and it owns a piece of all of those companies. So the nursing home itself is just this little core paying huge bills out to these other companies. And that's how they rip them up. And they end up having very little to pay staff on the nursing home side. Okay, next slide. Private equity owned healthcare companies were 21% of all healthcare bankruptcies in 2023. In other words, their model, when you buy something with a lot of debt and you don't really have an exit strategy other than selling to another PE firm or cutting costs and ruining quality, it tends to lead you in bankruptcy. So, and not all PE firms are like this. I mean, that's the sad news. Some of them would never do this. My system, UMass Health System, had a private equity deal where we joint ventured a specialty pharmacy management company, and we made $800 million out of it. Their exit strategy was to sell to Walgreens and make us all a ton of money. But this was not our core operation. This was a venture company off on the side. And that's the trick. You've got to figure out, what do you want to have in your state, and what do you want to encourage, and what do you not want to have in your state? Okay, the next slide goes into that a little bit. And tell me if I know I'm bumping into someone's time. So here's what they do that's negative. They borrow a lot, and the debt goes onto the operating company. So to acquire, they acquired Steward, Cerberus acquires Steward, puts their 240 million cash equity in, and then they incurred debt for everything else, including the capital promises they made, selling off the property and then leaving leases on the operating company. So debt is kind of their major way of financing things, and it gets left with the operating company. They sell the operating company real estate and take the cash to do whatever, include paying themselves dividends. They debt finance dividend payments that leaves the debt on the operating company, but they pay the owners. Ralph de la Tour did a debt finance, the owner of Steward did a debt finance dividend payment to himself because he bought Cerberus out and he got $100 million to go buy a yacht. They can outsource management services, and then they can cut costs, have fewer staff, and reduce unprofitable services, which are some of the things that we've talked about already. And that to the question of what do? This is what they do. Some of them. I mean, if they don't have a great way to grow and make money through a growth business, these are what they turn to. Okay, so remedies. I know you have someone coming from the National Academy of State Health Policy, and this is their model legislation. So rather than take up the next person's time, I'll leave all that. Massachusetts, why don't we go down to the last couple, which is about what Massachusetts has done. So Massachusetts has tried to increase reporting requirements. Steward was asked to give reporting, and they just blew us off. I found out about where Steward's status was because the SEC made their REIT force them to disclose their 2020s back in 2021. So it's very hard to get them to report. Whether if they don't want to, they just say go away. So the Massachusetts law also increases the penalties. Steward didn't pay them. We were penalizing them, but they didn't pay them. The third one, require vendors to give 60 days notice. We can do that, and I think that's important because in Steward's case, the vendors were repossessing medical supplies that were essential to saving people's lives, and so people died. You can ban the sale leaseback of an acute hospital's main campus. I would actually ban anything that's got to do with providing care, but they said the main campus. Don't allow them to sell it to a real estate investment trust, and disclose the level of the leases. The lease levels were 4 times what the hospitals had been paying in mortgages for their property. And then add a whole bunch, any kind of ownership change or real estate transaction to the types of processes that trigger some kind of state review. And then they said a 5-year monitoring period. Well, I was a part of the 5-year monitoring period for Steward, and they waited 5 years, and then they went off and sold their assets to a REIT and went on their spending spree. So I'm not sure 5-year monitoring period is enough. Okay, I'll stop there because I know that's my time. But if you want me to answer questions, please.
I think if you want to take another 5 minutes, because this is fascinating, frankly.
Yeah.
And this is a topic that, well, I know I don't know a lot, and I'm thinking maybe some people around the table may not know very much about. Tell us in 5 minutes, essentially what happened with Steward.
Okay, well, Steward started off acquiring the 6 Massachusetts hospitals owned by the Catholic Church called Caritas for $240 million when Cerberus was the owner of Steward. Cerberus was the private equity firm that owned the Steward holding company that owned the operating company. And for 5 years, they kind of behaved themselves, but they didn't put much, all the private equity company did was relieve Caritas of its tax-exempt debt. They paid that off because you can't have tax-exempt debt if you're a for-profit. And that was about $240 million. All the other costs, in capital costs, the $400 million that Steward put into the facilities as they promised the state they would, was borrowed and left on the operating company books. So when a private equity company says we're going to put we're going to make $400 million in capital investments, they don't mean their own money. They might mean the operating company is going to be liable for it. Anyway, by the end of 5 years, we wrote a report. It's on the Attorney General's website, and our financial piece said, "Gee, they've lost money every year, and they've incurred a lot more debt. Not sure this is going to work, but they done all these things they promised. They put the $400 million in. They didn't do everything they promised. They closed hospitals. They said they wouldn't, but we didn't have any alternatives. We didn't know how else to do it. And then after that monitoring period was over, literally the January 1, 2016, Steward sold all their hospital assets in Massachusetts over a year or two to a real estate investment company for $1.2 billion. the billion to 400 million or 500 million goes to Cerberus, a dividend, and the rest goes to acquiring hospitals in Texas, Utah. I can't remember exactly. I wrote a case about it, which I can send you. I was so frustrated. I wrote it all down. And they said they acquired all the other hospitals, and then they just went on and they just kept doing it, trying to, and then every time they acquired a hospital, they sold those assets, the capital assets, plant and equipment to MPT, the REIT, and got more cash to go do more acquisitions and more and more and more. But the debt, MPT was financing all this with short-term debt, with five-year or less debt. And when the real estate market, and when the interest rates started to rise, MPT was starting to struggle to refinance all the debt it had, because it had to refinance quite billions every year. And they started having trouble with that. So they started saying to Stewart, well, you got to pay these leases and start making money. And Stewart couldn't. And they finally imploded. But when the state kind of turned a blind eye, really, from 2015 to 2020. And I knew more than the state people did, because I was reading MPT's financials, and I'm just a little insane. And I saw that they were overvaluing Stewart's assets, and they were worried about Stewart's performance, but they kept telling their stakeholders everything's fine. And finally, I saw the 2021 financials, and Stewart had a minus $1.5 billion net worth, negative net worth, which meant it owed way more than it had in assets. And in a footnote, it owed another $4 billion. It wasn't even on their balance sheet in lease payments. I don't want to go into the accounting. So it was a disaster, and the state has had to try to take back we've had to close some of the hospitals. They all serve low-income populations. It's been a nightmare since then. And we've gotten back 5 hospitals. One is, the real estate has been awful. We can't get it out of Apollo for less than a certain amount of money. State tried to take St. Elizabeth's back, was through eminent domain. They're being sued. My health system, UMass, is going to build an emergency center right where one of the hospitals used to be, but we're not going to use their real estate because Apollo Capital won't let us have it for less than some outrageous price. So you probably don't want to know more than that, but I'll send you my case if you want to read it. And I guess I'm still saying some private equity is great. You just have to have it in the right place for the right people with the right idea, the right exit strategy.
Laurie?
I just want to provide, on the record, provide more clarity about what I was saying about the FQHCs in Vermont. As I said, people were concerned it was a private equity takeover of our independent health centers. In my community, it was a FQHC. And what it was is a company that has an ACO, and the company, Vitalize, is a private equity backed firm, or it was at the time. I don't know if it still is. But there's like I said before, there's no takeover. There's just an ACO-like arrangement that the health center has with Vitalize. And so far, it seems to be a positive thing.
Any other questions for Nancy?
I look forward to reading your case. This
I
is
know.
absolutely
It's
fascinating and
fascinating.
so unfortunate.
Yeah, I'll send it too. I'll send you the case I wrote, which I finished a year ago before the bankruptcy went in play. And then I'll send you another one that someone else wrote that goes after that period. So you can, so it's just a saga that hasn't stopped yet. It's terrible. But okay, so lovely chatting with you. I hope I
Thank
didn't.
you.
Thank you so much.
Thank you.
Take care.
Thank you. And next we have Michael, and Michael, is it Fenny? Fenny. It's the one I didn't try.
You almost had it on the first guess.
Welcome. Thanks for joining us today. And go ahead and introduce yourself and start.
All
Looking
right.
forward to hearing you.
Thank you for having me. Good morning. Thank you, Chair Black, Vice Chair McFawn, and members of the House Committee on Healthcare. My name is Michael Fenny. I'm a senior campaign and research coordinator for healthcare at the Private Equity Stakeholder Project, which is a nonprofit organization that seeks to bring transparency and accountability to the private equity industry for the benefit of impacted communities and limited partner investors. I appreciate you having me here to give testimony today. I'm going to focus on 3 things. And I'm so glad I got to hear Professor Kane's testimony, because she goes into more detail on some of the things I'm going to talk about. So that was great foundation. First, I'm going to talk about the private equity business model. Second, I'll talk a bit about the scope of private equity investment into healthcare beyond hospitals. And then finally, I'll talk about some potential risks from allowing private equity to operate without the appropriate oversight. I provided a document ahead of this meeting that will contain all of this information in much more detail. You won't need that document during my comments, but I will be focusing on a few of its key points, beginning with the private equity business model. So private equity firms are investment firms that take ownership of companies, healthcare facilities, healthcare providers, other entities, and generally aim to take that purchase and sell it for a profit within 3 to 7 years. In other words, private equity firms typically don't have an interest in making their companies financially healthy for the long term, and they're more interested in extracting wealth in that brief ownership period. I'm going to talk about some of the tactics that private equity firms use to take wealth from companies, beginning first with debt-based tactics. Private equity strategies can take what may be a solvent hospital providing vital services and within a few years put it deeply into debt so that it can't keep up with costs. How exactly does this happen? Two strategies, leveraged buyouts and dividend recapitalizations, are the main debt-based strategies that private equity firms use. I'll talk a bit about leveraged buyouts first. And Professor Kane described this with Steward acquiring Caritas in 2010. What a leveraged buyout is when a private equity firm takes out debt to buy a company. And the private equity firm buys that company, facility, whatever asset it is, using borrowed funds. But the private equity firm itself is not responsible for the debt. The company that it buys is now responsible for the debt. But the private equity firm still gets the benefit of owning and controlling that asset without being on the hook for paying that debt. What makes that especially concerning is that considering private equity short-term model, it means that if a private equity firm sells an asset within this short amount of time, it's possible and has happened that companies still have the debt that private equity firms put on them, even after they're sold by private equity. You all know a bit about Steward. They filed for Chapter 11 bankruptcy last May, reporting more than $9 billion in liabilities. Steward was formed through a leveraged buyout in 2010, as Professor Kane described, in which Steward took on $420 million in debt to purchase Caritas. I'm going to come back to Steward in a moment, but first I'll talk about the other debt-based strategy that private equity firms use, which are known as dividend recapitalizations, also referred to as debt-based dividends. This is when a private equity firm puts debt onto a company or a hospital that it already owns. And it does this so that it can pay a dividend to the hospital's private equity owners. The private equity firm receives a dividend payment using funds from this debt. The hospital, healthcare facility, or company doesn't get to use the funds from the debt to pay workers, buy supplies, or improve operations. A dividend recap is for the benefit of the private equity owner. Those are the debt-based transactions. I'm going to talk about the property-based transactions that private equity firms use. They use a tactic known as sale-leaseback transactions. A sale-leaseback transaction is when a hospital system sells its real estate to a buyer, typically a real estate investment trust, and starts paying rent to that same buyer in order to maintain hospital operations on the same real estate. So in 2016, Steward executed a $1.2 billion sale-leaseback with Real Estate Investment Trust Medical Properties Trust. As Professor Kane mentioned, proceeds from the sale went towards Steward's expansion into other states and also to pay $500 million in dividends to Steward's private equity owner. Meanwhile, Steward was left on the hook for rent payments on the same real estate that was once its highest value asset. So Private equity tactics, including the real estate play as well as the debt-based tactics, can put a healthcare system, can acquire a well-working healthcare system and within a few years leave it struggling. Steward went bankrupt last year, but its private equity owner had fully exited that investment by January 2021. And in the decade that it owned Steward, it made at least $800 million in profit. Zooming out a bit more, there are about 460 US hospitals owned by private equity as of 2024, representing 8% of all private hospitals and 22% of all proprietary for-profits. But none of those hospitals are in Vermont. So I'm going to take a step back now and talk about private equity in healthcare outside of hospitals and to an extent in hospitals, which I'll get to. So private equity has invested over $1 trillion in US healthcare over the last decade. It touches virtually every corner of the industry, not just hospitals, but outpatient providers, clinical research, durable medical equipment, home health and hospice, and many more. And the tactics tactics around debt and real estate that private equity uses to extract wealth from hospitals, private equity can also use those same tactics to extract wealth from other healthcare companies. So last year, 2024, we identified over 1,000 unique healthcare deals by private equity, including 166 buyouts and 621 add-on acquisitions. What are add-on acquisitions? Add-on acquisitions, or also known as roll-ups, are a key private equity tactic in which private equity firms consolidate companies within the healthcare sector. They use what are known as platform companies, which they own, and they use these to acquire and roll up smaller companies in the same sector. Roll-ups, add-on acquisitions have received some criticism from former federal agencies. Last year, the former FTC chair, Lina Khan, referred to the serial acquisition strategy used by private equity firms as a, quote, stealth consolidation scheme. In one press release announcing a public inquiry into serial acquisitions and roll-ups, she said, quote, firms can use serial acquisitions to roll up markets, consolidate power, and undermine fair competition, all while jacking up prices and degrading quality. So which areas have we seen the most activity in private equity in the last year? Last year, we identified the highest number of deals in dental care, health IT, outpatient care. And within outpatient care, the highest number of private equity acquisitions were in eye care, ear, nose, and throat, primary care, dermatology, and cardiology. The way that private equity firms consolidate outpatient care is to they utilize what are known as physician practice management companies, sometimes called management services organizations, which handle the business side of physician practices, including administrative tasks, marketing, bookkeeping, and financial services. Likewise, private equity firms in the dental sphere use a similar strategy, using what are known as dental services organizations to invest in the dental industry. And the dental services organization industry appears to have been created largely by private equity firms to avoid regulation that prohibits investor ownership of dental practices. So that's a bit about outside of hospitals. Going back to actually how private equity can get into hospitals without owning the hospitals, there are a few ways that this can be done. As scrutiny of private equity hospital acquisitions has increased, private equity firms have increasingly used joint ventures with nonprofit health systems as a growth strategy, giving PE firms access to trusted brands and markets that they may otherwise not be in. One example is LifePoint Health, which is owned by private equity firm Apollo Global Management. It's used joint ventures with nonprofits to construct or operate rehabilitation and behavioral hospitals in various states. And then in addition to joint ventures, there's outsourcing. Private equity can be present through hospital operations, management, consulting companies, which can provide a way for PE firms to take profits from nonprofit and public healthcare providers. One example is Ovation, formerly known as QHR. I think that there was some discussion of this company during Professor Kane's comments. Ovation is currently, it's one of the largest, or brands itself as one of the largest hospital management firms in the US. And they are currently, we checked the 990s for Springfield this morning. They are, as of 2024, they are the management company in Springfield Hospital.
I'm sorry, it broke up a little bit and I really wanted to hear what you said. Can you go back and
Page 6.
Can interrupt the electrical.
So there's a management company called Ovation that's private equity owned, and we only have limited information on where they're operating because we haven't looked at them specifically. But incidental to our research on this company, we found out that they are operating in Springfield Hospital. And so the broader point I think that can be made about their presence in Springfield is that there is more research that can be done in how private equity is getting into hospitals in ways that aren't owning those hospitals, whether it be joint ventures, management companies like Ovation working in Springfield Hospital, or a third way, physician staffing. Or actually physician and nurse staffing. Private equity firms own companies that provide staffing services for hospitals around the country. One such company is Envision Health, which as of 2022 had about 70,000 employees. They were acquired by private equity firm KKR in 2018 for $9.9 billion in what Reuters described as one of the largest leveraged buyouts since the financial crisis, which means that KKR put debt onto Envision in order to acquire that company. Envision filed for bankruptcy a few years later in 2023 and was split into two companies with two new owners. Notably, Envision's business model relied in part on a strategy of out-of-network billing to charge higher than average rates to patients via surprise bills. So there was some federal legislation that addressed part of Envision's business model. And then another staffing company that has gotten attention for private equity consolidation recently is US Anesthesia Partners. In January of this year, the company came to a settlement along with its private equity owner with the Federal Trade Commission for what the FTC alleged was anti-competitive conduct. The FTC had accused this company, US Anesthesia Partners, of engaging in a roll-up scheme by systematically buying up nearly every large anesthesia provider in Texas to create a single dominant provider with the power to demand higher prices. Last year, the company reached an agreement with the Colorado Attorney General to resolve a similar investigation into company practices. The Colorado AG actually compared the company's practices in Colorado to the scheme in Texas as well. So that's a bit about private equity scope. That is not exhaustive at all. The private equity gets into pretty much every area of the healthcare sector. And now I'm going to turn to some potential risks that come from private equity's involvement in healthcare. So due in part to private equity's business model based on short-term profits, using debt-based and real estate-based strategies, many private equity-owned healthcare companies have had quality and access issues. What we commonly come across in our work is we'll find a company that is owned by private equity has reduced staffing or fills hospital beds without adequate staffing ratios, over-reliance on unlicensed staff to reduce labor costs, and then failure to provide adequate training as well. And they'll put pressure on providers to provide unnecessary and potentially costly services. And we've also seen a lot of violations of the False Claims Act by companies that are owned by private equity. There's also a growing number of academic studies that confirm the role of private equity in driving up healthcare prices and costs for providers, payers, and patients. Some of these are described in the materials I sent beforehand. And this strategy, private equity's debt-based strategy, may also increase bankruptcy risk. Professor Kane talked a bit about bankruptcies through 2023. Private equity also played a disproportionately large role in U.S. bankruptcies last year, with PE firms playing a role in 27 of 48 largest U.S. corporate bankruptcies last year, or 56% of those bankruptcies. And for healthcare specifically, private equity-backed companies accounted for 7 of the 8 largest bankruptcies. I was going to end with just a brief cautionary tale about Steward and how they had a monitoring period for 5 years. Professor Kane went really well into that. And yeah, as soon as the monitoring period ended, Cerberus started using more extractive practices to profit from its ownership of Steward. So we would, in addition to thinking about policy prescriptions, we would think about not just transparency and merger review, but also limitations on some of these strategies, limitations on debt-based strategies, particularly leveraged buyouts, dividend recaps, and then also limits on sale leasebacks. That concludes my comments. I'll take any questions now. Thank you.
Ooh. Any questions? No,
Like I
I
need to take a semester.
know.
Study of this stuff.
Feel like maybe there's a series something exam for this. I don't know what number.
Can I ask a question
yeah,
just
of
for my own? So these hospitals and healthcare, they're entering into these probably not wanting to, but as a last resort to keep their, like, what is the incentive for the hospitals to get bought out by private equity other than to stay alive?
Sometimes the owners of a hospital can get a payout from the sale of the hospital. And a lot of these strategies that we're talking about that degrade the quality of facilities are just starting to get more and more attention in recent years. So an owner that maybe wanted a payout from the sale of their hospital or facilities would go through with that and maybe not be aware of the risks down the road.
Woody,
So can the Agency of Human Services stop a sale to an equity firm? Our Agency of Human Services?
I think that would probably be a question for maybe our legislative council and.
Our Jennifer Garvey, Legislative Council, our Agency of Human Services, I
Well,
doubt it, there's some potential for the Office of the Attorney General, but I think it would depend on the circumstances. I think a lot of what is in page 71 is authority that does not currently exist, or not specifically exist, but it's not a narrative expertise for me.
And I'll add, what we've seen in a lot of states is that there are not limitations on private equity firms specifically. We see a lot of states that have merger and acquisition review laws that they use to review proposed private equity transactions. And some states also have the ability to put conditions on those acquisitions, which we've also seen. But there are not limitations on private equity itself. And also, a lot of what we've seen in those other states, the conditions that attorney generals or health departments, for example, are able to impose aren't really adequate to addressing the scale of private equity's ability to extract wealth from a company, whether it be as soon as it buys it or 5 or 6 years down the line in the way that Cerberus did with Steward. So we're really, as an organization, trying to emphasize addressing these extractive tactics that private equity uses related to debt and real estate. Those seem to be where the largest harms are.
Are you aware of, are any other states currently working on this sort of thing, or have any states enacted recently?
Several states are looking at it, and a few have enacted acquisition review laws. I don't have the details of those at my fingertips, so I'll actually send you. We prepared a report that we released a couple months ago that summarizes a lot of the recent policy activity across the country in various states related to private equity. So I'll send that after this meeting.
Okay, that would be wonderful. Thank you. Yeah, we have a question from the side of the room. Oh, a comment from around the room. Sure. Michael, do you mind if our healthcare advocate has a seat here briefly?
Mike Fisher, healthcare advocate. I really want to thank the committee for taking the time today and tomorrow to look at this issue. We think that Vermont, we don't know the extent to which private equity is already here in Vermont, but we also think, given the instability in our healthcare system, there is a lot of risk. And so we have Sam is the expert on this, so you're going to hear from him tomorrow. But we think that that this is a really important issue, and I really wanted to appreciate the committee for taking some time doing a little bit of a crash course with some experts. You're going to get some more experts tomorrow, I think. And also just to say on a high level, we're not saying, like Nancy just said, we're not saying private equity is bad. We're saying some of the practices that private equity tends to use, the extractive techniques, should be prohibited in this state, and that we have some work to do to make sure that we have appropriate review of those activities. So I just wanted to jump in the seat and say thank you. And I realize that it does feel like a crash course and a college course, and look forward to working with the committee. I think, mostly next year on taking a serious look at our statutes and what we need to do to make sure that we don't allow these kinds of activities.
Would you say that some of the current fragility in our healthcare system makes us more vulnerable to, even if we're not experiencing it now?
Absolutely. Absolutely. I think the analogy that comes to my mind is a payday loan. Nobody wants to pay a huge rate. Nobody wants to do, to make a deal that they know is going to be really hard for them to get out of. But sometimes people or entities feel like they've got no choice. And so, with that instability and that financial pressure, I think there is more risk.
Daisy, did you?
I'm just curious if you have anything to say, following Michael and Nancy, about how, if a situation like this were to take place in Vermont, what would the impact be on patients?
Yeah, I think you'll hear more about it tomorrow. I think that some of the testimony that Sam has prepared sort of goes in a little bit more into more detail, just how this hurts people. But I think all I can do is reflect on what I just heard. Higher costs and healthcare systems that get pulled apart, loss of access to care.
I don't know whether anybody can answer this, but how can you tell if a private equity firm is involved with a hospital or nursing home or something in the very beginning? Is there any way to tell, or is anyone watching that?
I can jump in. There is generally not any way to tell what private equity is doing, what it's buying, if an acquisition is private equity, unless they tell us. A lot of the companies that we learn about are through press releases of a private equity firm. Each private equity or many private equity firms also maintain a page on their websites with portfolios. And we track down information that way. But as for disclosure at the time of purchase, that is generally not something that private equity firms or the companies they buy have to disclose.
Mari?
As the case in Springfield, the Hospital 990s, there's a 2-year lag time, might show that there's a relationship with a private equity firm.
There's been a private equity firm relationship in Springfield since at least 2021. And in the latest one that we looked at this morning. So at least for that period, there was a relationship with the management company that operates in Springfield Hospital.
I guess I'm saying Hospital 990s might be one indication that something is going on.
Yes, and the way that we found that is on the very last page, there was a note about how Ovation determines the salary of the company or of the hospital CEO. So there are little traces that we have to follow the breadcrumbs to piece together a larger picture of what private equity is doing.
Leslie?
I'm not sure that this is necessarily the question, but given Springfield Hospital's dire situation a couple of years ago, which taxpayers rescued, and apparently, and this is new information to me, that this private equity firm still sounds involved with Springfield Hospital. And given that Springfield Hospital is still significantly in the red, how do we get our heads around moving through this problem? And who is in charge of it? I mean, I don't know if this bill will help with that, and that's good. But what about in the meantime?
Right.
As we see, I'm really concerned here.
Yeah, I think two things. I think I would turn to the witnesses again if there's any time to, I think that they described how a private equity firm can make money on a hospital that's losing money. That's counterintuitive. I keep turning around. You're in front of me, I know, but your picture's behind me. And so I don't know if either of the witnesses, Nancy or Michael, have anything to say again about that dynamic.
Can I just add one thing for the record? The way that people found out that Springfield Hospital is going bankrupt was the ophthalmologist went to work that morning and there was no heat. And the reason there was no heat is no one paid the bill. So that was an absurd situation, which then crashed, obviously. Ovation is still involved. So how do we have confidence that this hospital is being managed appropriately?
I mean, I think that the concern behind your question, I don't know how to give you any comfort. I think I share that concern that that during this time we don't have a regulatory structure that prevents the really bad practices, and that's what the bill seeks to do. And we're going to the public interest is going to all have a decision to make whether the effort to put in place that regulatory structure is worth it. Today and tomorrow, I think we're here to make the case that there's significant reasons to do so, that there's real risks to our healthcare system.
And I'd like to add one more thing.
Yeah, I'd like Michael and Nancy to have the opportunity to see if they wanted to weigh in on Mike's question. Mike, Chief, you had a question of how exactly you profit off of somebody making no profit. That was the gist of the question?
Yeah, it's counterintuitive. And if Nancy or Michael could say anything about the dynamic of how a private equity firm could be making money off of a health system that's losing money.
I think, can you hear me? I'm not sure I'm unmuted.
Yep,
Okay.
we
Yeah,
can
I
hear
mean,
you.
it's exactly what Stewart did. They sold their capital assets to a REIT. And then stop paying suppliers, just like your hospital you're talking about. You know, you can try to get some kind of early warning system when vendors are starting to say you're not paying my bills. And you can track accounts payable. I mean, days in accounts payable shot up for Stewart in around 16, 17. They stopped paying their bills. But if they want to sell their capital assets to a REIT, that's a big red flag that should have state oversight. That's the biggest one.
I mean,
And then
essentially,
the other way they do it is they start cutting off services that are unprofitable, close the OB unit, close the adolescent psych unit, close the, this, that, whatever, ED that has too many in the poor neighborhood, or, close the clinic that's lets poor people in.
so essentially, if I'm understanding, they took what had been an asset and turned it into a liability
No,
on
they
the
took
balance
it.
sheet.
Well, yeah, in a way, you're right. They sold their hospital buildings and equipment
And then leased it back.
and leased it back for 4 times what they were paying in mortgage payments.
Um,
But the cash came in for the sale, and they used it to pay dividends to Cerberus and then go acquire other hospitals. But the leases stayed on the operating company books.
I think maybe Devin wanted to, I'm sorry, I interrupted. Michael, did you wanna?
And I think that gets to Stewart's bankruptcy a few years down the line after it was sold by Cerberus, because they were still carrying a lot of the liabilities and debt that Cerberus had put on them.
Yeah.
Under private equity ownership.
Right. They didn't use that cash to retire debt.
I think Devin Green maybe wanted to weigh in. I was gonna say from the cheap seats, but.
Devin Green from Buzz. I have to do gymnastics pickup in 2 minutes. So I'd like an opportunity to testify at some point.
Oh.
If we're gonna.
Oh, absolutely.
With this, but I'd also just like to specify that I think there's a difference between a management organization similar to the ACO connection as opposed to pieces and selling off the pieces. There are different things that we're talking about here. And then also the strategy of closing down unprofitable service lines is also in Act 167. So it's not limited to private equity.
That's the question actually that has been swirling in my head. The whole thing is, this isn't just limited to private equity. Leslie, one more last thought.
One more comment, if I may, I'm sorry. This is also new information, so I'm a little surprised when you mentioned the CEO of Springfield Hospital being employed by Ovation. And Springfield Hospital, when we talk about transformation, is really trying to do the same thing over and over again, expect a different result. And now it's like, oh, aha, that they're being managed and directed by this private equity firm. And who knows what's going to happen in an ongoing way. So all very disturbing.
Thank you. And again, I just wanted to reiterate, this was just, we have some time this week before Senate bills. This has been a bill that's been sitting on our wall since, I don't know, when we were in the 70s. And I just wanted to introduce the topic this week. And obviously, if this is something that we want to talk about or something that we'd like to take up in the future, then we will have lots and lots and lots of testimony. So I think we're going to end with that topic today. I appreciate, we did have to bump everybody back an hour. So I appreciate everyone flexing on this. And tomorrow morning, we're going to hear from the 2 parties that we weren't able to do because our floor went so long in caucuses today. All right, so thank you so much, Michael and Nancy. Really great information and a great topic.
Thank you so much.
Thank you.
Thank you.
Thanks for joining us.
Thanks for having us.
Bye-bye.
Okay, so why don't we take just a 1 or 2 minute break so that our next witnesses can get into the room, because I think they might be out in the hallway. So let's take a minute or two. Oh,